Good morning, one and all. Welcome to the session of KIMS Cuddles online education. Today in this video, we will discuss about acute kidney injury in neonates. So acute kidney injury is one of the most common causes of morbidity among sick babies admitted to the NICU, and it also leads to long-term sequelae. So early identification of acute kidney injury in neonates and treatment for the same helps in saving many lives. In the coming 30 to 40 minutes of the video, we will discuss about the different aspects of acute kidney injury, such as introduction, definition of AKI, the epidemiology and risk factors for development of AKI, as well as a few slides on renal development, classification and approach to AKI, and improvement in diagnostics, management, like peritoneal dialysis, hemodialysis, CRRT, and the outcomes in such babies. So I have mentioned few examples which predispose to AKI among babies admitted to the NICU. So in the first case, an extreme preterm 28 weeks, 980 grams baby born to a mother with a PPROM of 36 hours. Baby cries immediately at birth with an UPGARS of 6 and 8 at 1 and 5 minutes respectively. Baby was admitted and started on delivery room CPAP, followed by surfactant was given by Ensure technique. In view of PDA, baby was started on indomethacin and first line antibiotics were started. Because the baby had skin bruises, gram-positive coverage was also given. So subsequently, feeds were hiked for this baby. On day 12 of life, baby had NEC changes on X-ray, for which antibiotics were upgraded. When monitoring the creatinine levels for this baby, the creatinine shoots up from 0.7 to 1.3 milligrams per deciliter. The risk factors in this baby for AKI are prematurity, sepsis, needing higher antibiotic support, as well as PDA. In the second case, an early term 37 plus 5 weeks baby presents on day of life 2 with cyanosis and respiratory distress. Initially, respiratory support was given. Echo shows obstructed supracardiac TA PVC, for which the baby undergoes cardiac surgery on bypass. Post-operatively, the baby goes into refractory shock, needs multiple inotropes, and aka dialysis was being initiated. So for this baby, the risk factor is cardiac surgery. In the third case, a full-term baby born out of normal delivery has perinatal asphyxia with low UPGARS and ventilated at birth. Surfactant was given in view of meconium stained liquor, and baby was started also on therapeutic hypothermia. Baby goes into catecholamine resistant shock and has decreased urine output on day of life 2. The risk factors in this baby for AKI are perinatal asphyxia and shock. So what is acute kidney injury? It is a sudden impairment of renal function resulting in a decrease in glomerular filtration rate and accumulation of nitrogenous waste products, as well as fluid, electrolyte and acid-base imbalance in the body. AKI is an important cause of morbidity, mortality, ventilator requirement, and increases the length of hospital stay, as well as leads to the chronic kidney disease in the long run. So coming to the classification of AKI, there were many classifications which attempted to define the acute kidney injury in neonates. First, the rifle classification was there. In that, when there was a 25% decrease in the creatinine clearance, it was classified as risk. Then injury is classified as 50%, failure 75%. And when there is loss of renal function for 4 weeks, it was categorized as loss, and end-stage renal disease if the kidney injury lasts for more than 3 months. So this was mentioned as rifle. Then later on, the KDIGO classification came into work, and which was subsequently modified for neonates. So currently, we are now following the modified KDIGO classification for staging the AKI, which is staged as three stages, with taking the creatinine and urine output into account. Stage 0 is no change in the serum creatinine or an increase in the creatinine less than 0.3 milligrams per deciliter, and the urine output being normal, that is more than 0.5 ml per kg per hour. So whenever the creatinine increases beyond 0.3 milligrams per deciliter within 48 hours, or a rise from the baseline to 1.5 times with a urine output of less than 0.5 ml per kg per hour for the last 6 to 12 hours, it is categorized as stage 1. Stage 2 similarly is a rise 2 to 2.9% above the baseline and a urine output less than 0.5 ml per kg per hour for more than 12 hours. And stage 3, when it goes beyond 3 times from the baseline or any creatinine value more than 2.5 milligrams per deciliter, is defined as stage 3 of AKI, because the glomerular filtration rate at this value is usually less than 10 ml per kg per 1.73 meter square, or any kidney support utilization is also categorized under stage 3, with a urine output less than 0.3 ml per kg per hour for more than 24 hours, or anuria for more than 12 hours. So although serum creatinine is used in many of these classifications to define the AKI, it has many shortcomings. So mainly, initially at birth, the serum creatinine reflects the maternal values, and it is also linked to the maternal renal disease or maternal placental dysfunction. And the values of serum creatinine in a baby gradually decline by 3 to 4 weeks of age. And the creatinine measurement also varies with the age, gender of the baby, and neonates with less muscle mass obviously have less serum creatinine, and also on the hydration status of the baby. Creatinine values also depend on the type of assay which is used to calculate them. So bilirubin levels tend to interfere with the creatinine values if the Jaffe type of assay is used. And it is a late functional marker which rises 24 to 48 hours after the insult, or until 25 to 50% of the renal function is lost. It also doesn't indicate the nature and timing of the insult. At low GFR, the serum creatinine will overestimate the renal function. So among non-oliguric AKI, which contributes to 60% of the AKI in neonates, the rise in serum creatinine helps in diagnosing the AKI for these babies. So among non-oliguric AKI babies, creatinine is a useful marker to diagnose the renal injury. So coming to the AWAKEN study, which is the assessment of the epidemiology of AKI in neonates worldwide, they have taken the criteria as a rise in serum creatinine as more than 0.3 milligrams per deciliter, or more than 50% from the previous value, and the urine output was considered as less than 1 ml per kg per hour in the last 24 hours. So 2022 neonates were taken into the study after ruling out the other criteria. So the incidence of AKI was found to be 30%, and it varies widely with gestational ages, as we will see in the next slide. So what they found out was neonatal AKI was a common and independent risk factor for mortality and longer hospital stay. In this study, the types of RRT used were peritoneal dialysis in 9 babies, CRRT in 4 babies, CRRT plus ECMO in 11 babies, and PD plus CRRT in 1 baby. Intermittent hemodialysis was not used. So infants with AKI plus CRRT had lower survival in the study. So coming to the incidence of AKI with the gestational age, as we can see, in between the gestational ages of 22 to 29, the incidence of AKI is very high. That is around 48% of the babies go into AKI. But in the babies with between 29 to 36 weeks of gestation, the incidence is lesser, around 18%. And again, in the term babies, like more than 36 weeks of gestation babies, the incidence climbs up to about 37% again. This is because of more of outbound asphyxia and transport after birth. Sepsis, all these factors come into play here. In the premature group, the PDA, sepsis, and need for respiratory support, all these factors all contribute to the incidence of the AKI. So now let us see the natural progression of AKI. It can be divided into these categories. That is, initial is the pre-renal insult. So what happens when there is a pre-renal insult to the kidney? So like dehydration for the baby, increased insensible water losses, hypovolemia. So whenever there is a decrease in the renal blood flow, the kidney preserves the glomerular filtration rate by increasing the sympathetic tone and activating the renin-angiotensin-aldosterone system, and increasing the activity of hormones like vasopressin and endothelin. So this leads to water and sodium reabsorption and maintenance of the intravascular volume for the baby. In some neonates, there might be poor vasopressin response, which leads to hypotension and shock as well as prerenal AKI by decreasing the prolonged kidney hypoperfusion as well as ensuing the parenchymal damage. So subsequently, this prerenal AKI may transition to acute tubular necrosis and tubular cell damage. So if the restoration of so we identify the baby by the early signs of shock like tachycardia, feeble pulses, and decreased IVC diameter, and replace the volume for the baby. The restoration of renal blood flow may occur, and the kidney function may revert to normal at this stage itself. If not, then the initiation of renal injury begins, which is shown by a drop in the glomerular filtration rate. So here, acute tubular necrosis as well as corticomedullary necrosis also occurs because the kidney gets exposed to the inflammatory toxins. Then the extension phase continues due to continued hypoxia and alteration in kidney function as well as inflammatory insult to the vasculature. The maintenance phase duration depends upon the initial insult for the kidney. So it may last up to 1 week also. Then it is followed by the recovery and restoration of the glomerular filtration rate. This may continue for months. So when we see the baby according to the gestational age, the baseline creatinine values in 25 to 29 weeks are 0.87 to 1.18 with the GFR being 13.4 to 14. And as the gestational age increases, the creatinine value gradually comes down. And in a term baby, the normal baseline creatinine value will be 0.61 to 1 with a glomerular filtration of 27 to 28.4. So now let us see a few lines about the renal development. In utero, the nephron development begins by 5 weeks and continues till 36 weeks, among which 60% of the nephrogenesis occurs only in the third trimester, with each 1000 grams increase in the birth weight, the baby adds 2 lakh nephrons to its kidney number, and the functional maturation of kidney occurs till 2 years of age, where adult GFR will be reached. So you can imagine when a baby is born at the end of the second trimester or in the beginning of the third trimester, the baby is born with as such a low set of nephrons, and they are also prone to lot of insults postnatally like sepsis, nephrotoxins, drugs. So that is the reason the premature babies are more prone to AK. So the normal nephron number in adults is varies anywhere between 2,10,000 per kidney to 2.7 million per kidney. So what predisposes the babies to AKI? It can be divided under 3 categories. So the blood flow to the kidney naturally increases after birth from 5% of the cardiac output to 20% of the cardiac output by 2 years. This happens gradually. So majority of the increase in the renal blood flow occurs in the first 2 weeks. So whenever the distribution of the renal blood flow to the kidneys is affected by either nephrotoxic drugs like indomethacin, other antibiotics, or asphyxia, or any hemorrhage, or prerenal AKI. So this predisposes the kidney to the AKI. And neonates are inherently having low glomerular filtration rate, which is again affected by postnatal stressors like sepsis, hypoxia, and hypotension. And the urine concentrating ability of the kidneys are naturally low for a newborn, which leads to decreased intravascular volume as well as renal perfusion, and insensible losses in a preterm baby also implicates the baby towards AKI. So let us go on now. We will see the factors which affect the in utero renal development. In utero, the protein and calorie restriction for the mother as well as the vitamin A and vitamin D deficiency leads to the decreased nephron number in the baby. Vitamin A and vitamin D also contribute to ureteric bud branching. Active vitamin D also stimulates the cell differentiation in the kidney. Maternal exposure to drugs like aminoglycosides, AC inhibitors, AT receptor antagonists, NSAIDs, corticosteroids, alcohol, and tobacco also contribute to the decrease in the nephron number. And maternal hyperglycemia should be always inquired into. This also affects the kidney function. IUGR babies, as well as any congenital anomalies of the kidney and urinary tract, should also be documented. And whenever there is any iron deficiency also, the hepatic mobilization of vitamin A is affected, subsequently leading to the decrease in the nephron number. Postnatal factors affecting the renal development are prematurity, IUGR, low birth weight, and need for higher frequency ventilation, inotropic support, PDA, hypovolemia, sepsis, nephrotoxic medications, any cardiac condition requiring surgery, hypoxic ischemic encephalopathy, NEC, and extracorporeal life support all affect the renal development. Coming to the nephrotoxic medications and the way they affect the kidney, we will briefly see one by one. So, among the NSAIDs, the indomethacin inhibits the prostaglandin and also decreases the renal blood flow. Ibuprofen, which is also used for closure of PDA, has a lesser renal injury compared to indomethacin. Among the antifungals, amphotericin B affects the tubular function, as well as these aminoglycosides affect the proximal tubules, leading to the cell damage. So all these nephrotoxins cause acute kidney injury by decreasing the renal perfusion, causing tubular injury, as well as interstitial nephritis and tubular obstruction. Acyclovir particularly obstructs the distal tubules and causes the crystallization in them. So in a study called as Baby Ninja study, which is nephrotoxic injury negated by just-in-time action, they have frequently monitored the serum creatinine, and they found out that the monitoring of the serum creatinine decreases the nephrotoxic medication exposure in the babies from 16.4 to 9.6 per 1,000 patient days, leading to the reduction of the AKI from 9.1 to 2.9 per 100 patient days. So regular monitoring of serum creatinine in high-risk babies as well as in babies who are being exposed to nephrotoxic medications is very important in our day-to-day NICU practice. So coming to the classification of AKI, 80% of the AKI comes under the pre-renal category, with 11% being intrinsic renal and post-renal causes being 4%. Among the pre-renal, it can be divided into various subheadings like reduced effective circulatory volume, which is seen in conditions like dehydration, insensible water losses, hemorrhage, and excessive use of diuretics. And capillary leak is seen in conditions like sepsis, hydrops, and hypoalbuminemia. Any abdominal conditions like NEC, gastroschisis, omphalocele also leads to increased water losses from the body and lead to pre-renal AKI, as well as cardiac conditions needing surgery. And increased renal vascular resistance is seen in the case of polycythemia, drugs like indomethacin, as well as using inotropes, adrenergic drugs. And the other condition is hypoxia and asphyxia, leading to pre-renal insult. Intrinsic renal injury is seen when there is a damage to the glomeruli, tubules, and the interstitium. So in which the hypoperfusion can also lead to ATN with intrinsic renal failure. That is, the pre-renal can also transition to intrinsic renal. Intrinsic renal injury is also seen in congenital anomalies like agenesis, hypoplasia, and polycystic kidney disease, and in thromboembolic conditions like bilateral renal vein thrombosis and renal artery thrombosis. So if you encounter a neonate with oliguric acute renal failure with hematuria, hypertension, and loss of femoral pulses, we should always think about renal artery thrombosis. Similarly, in a baby with bilateral flank mass, proteinuria, hematuria, oliguria, and thrombocytopenia, in this setting, renal vein thrombosis should be suspected. And so in this, there will be a setting of polycythemia, maternal diabetes, and dehydration also. In such cases, we should immediately do the renal Doppler to look for both these conditions, renal artery thrombosis and renal vein thrombosis. And any exposure to nephrotoxins, as we have discussed earlier, leads to intrinsic renal failure, as well as infections of the kidney like congenital infections, pyelonephritis, and hemoglobinuria, myoglobinuria lead to intrinsic renal failure. Coming to the post-renal causes, any obstruction to the urine output from the kidney, the most common cause is posterior urethral valve and stricture, urethral diverticulum. So all these conditions should be suspected like whenever there is a decrease in the urine output, and antenatal scans should also be inquired into, and syndromic baby having prune belly syndrome, and bilateral pelviureteric junction obstruction, uretrovesical junction obstruction, all these can be found out by ultrasounds, and nephrolithiasis, ureterocele should also be looked into. Any neurogenic causes like neurogenic bladder and extrinsic compression by sacrococcygeal teratoma can also cause post-renal acute kidney injury. So coming to the most important aspect of approach to the acute kidney injury. So whenever we are having a baby with decreased urine output, our history taking should start from the antenatal period, like any history of maternal intake of drugs like NSAIDs and diabetes, having maternal diabetes, and the other medications which we have discussed earlier, as well as maternal history of oligohydramnios or polyhydramnios, or any Doppler abnormalities leading to IUGR, any family history of polycystic kidney disease or congenital nephrotic syndrome, any baby with high drops. So immediately the congenital nephrotic syndrome should be thought about and further investigated for the same. Any history of intrapartum like asphyxia, delayed cry needing resuscitation, CPR, and delivery room intubation should also be inquired into. Postnatal causes like hypovolemia needing volume resuscitation, boluses, sepsis needing medications, as well as other drugs like NSAIDs for closing the PDA, and cardiac conditions, any other surgical conditions like abdominal surgeries and all should be inquired into. Coming to the examination of the baby, we should do the head-to-toe examination, look for dysmorphism and other anomalies, as well as the vitals of the baby, heart rate, pulse volume, and whether there is any tachycardia, and whether there is volume overload or volume deficit, monitoring the IVC, and looking for the bladder, and noting down the BPs, whether the baby is in any hypotension or shock, features of sepsis, prolonged CFD. These things should be examined, as well as we can get done ultrasound for genitourinary abnormalities, and also look for any renal vein thrombosis or renal artery thrombosis by monitoring the Doppler status. So coming to the monitoring, it depends upon the each and individual condition of the baby, but generally we should monitor for the urine output by catheterizing the bladder, and keep a strict intake output chart, and take care that the baby does not go into either volume overload or depletion. Lab wise, we will investigate the baby according to these parameters, like doing the electrolytes, urea, creatinine, and arterial blood gases to look for metabolic acidosis. Any acidosis less than pH of 7.2 should be treated, and we should also look for urine osmolarity, sodium, and creatinine, from which the renal failure index and fractional excretion of sodium can be calculated. Urine microscopy should be done to look for casts, RBC, proteinuria, and hematuria. Any casts or RBC or proteinuria in the urine is an indicated for acute insult like asphyxia or any intrinsic renal causes. Renal Doppler and ultrasound for anomalies like polycystic kidney disease, dysplasia, and obstructive uropathy should be done. So fractional excretion is defined by the urine sodium into serum creatinine into 100 divided by serum sodium into urine creatinine, and the renal failure index is documented by urine sodium into serum creatinine by urine creatinine. Always the urine creatinine ratio will come in the denominator. So how to differentiate based on these definitions? So pre-renal AKI will always have a blood urea nitrogen by creatinine ratio higher than renal, and in pre-renal AKI the urine specific gravity and urine osmolarity and all will be always high. Urinary excretion of sodium will be low because the kidney functioning is as such good, whereas in intrinsic renal AKI the specific gravity, osmolarity and all will be low, and urine sodium will be, obviously there will be a sodium loss in the urine, and the fractional excretion of sodium is also higher in intrinsic renal injury, and the renal failure index is also more than 4. So if you have diagnosed the pre-renal AKI for the baby, we can give the fluid challenge followed by 1 dose of Lasix. So coming to the novel biomarkers for AKI, other than serum creatinine, some other biomarkers have been studied in the diagnosis of AKI. These are the cystatin, neutrophil gelatinase lipocalin, kidney injury molecule 1, TIMP1 and IGF-BP7. So cystatin reflects the kidney function and not injury. The proximal tubular injury is also documented by increase in the serum cystatin C levels. So whenever there is an increase in the cystatin C levels, there is a change in the GFR or kidney function. Elevated urine cystatin C levels indicates the tubular injury. And the neutrophil gelatinase lipocalin, the location of injury is the distal tubule and the collective duct. This indicator is highly sensitive for ischemia and nephrotoxins. Kidney injury molecule 1 elevation indicates the proximal tubular injury, and it regulates the apoptosis and promotes the epithelial regeneration. The TIMP2 and IGF-BP7 indicate the injury as tubular cells. It limits the proliferation of the damaged tubular cells, and it is also an early marker for AKI. So the nephron number by MRI and tissue oxygenation by near infrared spectroscopy are also higher advanced tests for the diagnosis of AKI. So how to calculate the glomerular filtration rate? It is done by the K into L by serum creatinine in this formula, where K is a constant which is taken as 0.34 in preterm babies and 0.45 in term babies. So coming to the management of AKI, obviously supportive care should be started for any baby, and treating the antecedent causes like dehydration, sepsis, treating sepsis with proper antibiotics, and adjusting the antibiotics according to the renal doses. And first palpate the bladder for any urinary retention. If not, the bladder can be seen by ultrasound and catheterization can be done. And if still there is no urine output, and if you are suspecting a pre-renal cause, fluid challenge can be given up to 10 ml per kg over 1 hour, followed by a single dose of furosemide. So if there is a pre-renal AKI, it will respond to this treatment. Further fluid boluses and furosemide are not of much use. So if there is a further AKI with intrinsic renal failure, the total fluid intake output should be strictly monitored, and it should be restricted to the insensible water losses plus urine output, which is usually 40 to 80 ml per kg per day in any baby. And the baby should be watched for electrolyte abnormalities. Hyponatremia is generally due to water retention, excessive water retention. So if we restrict the fluid volume, the hyponatremia should settle. And if there is a severe hyponatremia, less than 120 milliequivalents, then the correction should be given according to the formula 0.6 into 8 into difference. We should not correct more than 10 milliequivalents per kg per day. And severe hyponatremia or refractory hyperkalemia, which is not responding to treatment, is an indication for renal replacement therapy. Hyperkalemia, whenever the baby is noted to have, we should monitor the cardiac function by doing an ECG and also an echo. And we can stabilize the myocardial membrane by giving the calcium. And also we can decrease the hyperkalemia by starting the insulin dextrose infusion. Similarly, hypocalcemia and hyperphosphatemia also should be treated. So So any hyperkalemia leads with the reduction in the glomerular filtration rate leads to decreased potassium excretion and acidosis, as well as immature tubular response to the aldosterone and cellular breakdown. These are the reasons for hyperkalemia. So whenever the baby is noted to have hyperkalemia, we should stop giving the potassium containing fluids and also the drugs like indomethacin and AC inhibitors. So as we discussed, for pre-renal AKI, fluid followed by diuretic challenge as well as isotonic saline and colloid can also be given. And hypoperfusion should be corrected by properly treating with inotropes. Hydrocortisone and albumin also can be given if needed. For intrinsic renal failure, the hypertension should be monitored if there is any hypertension secondary to hyperrenemia. The antihypertensives like amlodipine, beta blockers, and AC inhibitors can be used. Appropriate calorie balance should be maintained with the calories of around 100 kilocalories per kg per day and protein intake of at least 2 grams per kg per day should be maintained, and monitor the values of lab parameters. For post-renal AKI, the only treatment will be the relieving of obstruction and fulguration in a case of posterior urethral valve and nephrostomy if indicated. So, there was a Cochrane meta-analysis which studied the role of dopamine in preterm neonates being treated with indomethacin for PDA. Dopamine at low doses acts on the DA1 and DA2 receptors and increases the renal blood flow. However, in preterms, they are hypersensitive to the alpha receptors, and even dopamine can also cause renal vasoconstriction. So this analysis ruled out the no role of dopamine in preterm neonates treated with indomethacin, and the result was no improvement either in the survival or in the dialysis requirement in such babies treated with dopamine. Theophylline was also studied. Theophylline is an adenosine receptor antagonist. It prevents AKI by inhibiting the adenosine-induced renal vasoconstriction. Theophylline was found to be beneficial in a meta-analysis of 7 RCTs of 458 neonates with asphyxia not receiving therapeutic hypothermia. Theophylline administration lowered the incidence of AKI. A single dose of theophylline within the first 6 hours in newborns with HIE can be tried to prevent the AKI according to the 2012 KDIGO guidelines. So caffeine also has a similar action. It is an adenosine receptor antagonist. So caffeine helps in preventing the AKI in preterm babies and VLBW babies and babies less than 33 weeks of gestation if given in the first postnatal week. The Awaken study also confirms the same, and the number needed to treat is like caffeine to prevent one episode of AKI was 4.3 neonates. So caffeine and theophylline are useful in treating the AKI. So whenever we are done with all these general measures and there was no improvement in the either in the lab parameters or in the creatinine values or urine output, then we should think of renal replacement therapy. It is done under 3 modalities. The most common is the peritoneal dialysis, and the second one is intermittent hemodialysis, and followed by CRRT. The choice of each depends upon the patient characteristics, patient's condition, and feasibility to do one of the above methods, as well as the available resources, trained staff, and the experience of the center doing the same. So PD is most commonly used, done everywhere. So the indications for RRT being hyponatremia with fluid overload, electrolyte abnormalities like hyperkalemia, hyperphosphatemia, and hypocalcemia, severe metabolic acidosis or uremia, refractory to medical management. So how does the peritoneal dialysis works? It works by ultrafiltration, which helps in the removal of the water, and dialysis, which is the process of removal of the plasma solutes by diffusion down their concentration gradient across a semi-permeable membrane. So here if you take this as the abdominal or bowel wall, and this is the interstitium, and this is the peritoneal cavity with the mesothelial lining. So there are 3 layers from the blood in the capillaries to the fluid in the peritoneal cavity. That is first the capillary wall, the second is the interstitial gel-like matrix, and the third one is the mesothelium. So among these, the pore sizes will vary between smallest pore of size 4 to 6 nanometer, which allows the small solutes to transfuse like urea, creatinine, sodium, and potassium by diffusion mechanism. And water goes by convection in the smallest of pores, and the macromolecules can pass only through pores which are more than 20 nanometer in size by hydrostatic forces. So let us see the differences between and advantages among the different methods of RRT. Peritoneal dialysis is easy to learn, easy to perform. It can be done bedside, and vascular access, large venous access is not required. Of course, we will need either a PICC line for maintaining the shock and all those things. And here the peritoneal lining acts as a dialysis membrane, as we have seen earlier. And the smallest documented survivor after peritoneal dialysis was a baby with a weight of 830 grams. Smallest catheter can be used, either a rigid PD catheter or a flexible 10-cough catheter can be used for performing the peritoneal dialysis. Rigid catheter is used whenever we anticipate a short-term use of PD. Flexible catheter should be placed if we are going to use it for a long term. Hemodialysis, there will be a lot of temperature fluctuations whenever we do hemodialysis. There will be large fluid shifts and there is a risk for hemodynamic instability. Technical difficulty and vascular access is a main concern, and the tubings of neonatal size should be looked into. That is, the staff as well as the center experience plays a major role here, but it is the initial modality for rapid treatment of hyperammonemia. Nowadays, a continuous renal replacement therapy, CRRT, is being performed in many centers along with the ECMO for very sick, critically ill babies, along with SLED, the slow low effusion dialysis. That does not cause these excessive fluid shifts, and it can be done in critically ill babies. Vascular access needs to be secured. The babies need to be kept on systemic anticoagulation. It can also be done in babies undergoing ECMO, and as it can be connected to the ECMO circuit, and it is the preferred method if peritoneal dialysis is contraindicated due to any abdominal conditions. There is a need for strict volume control. There is an NEC, then the CRRT can be thought of. So the smallest volume is around 33 ml for Aquadex machine, and Carpedium machine was used as early as in 2013-14, where the smallest weight of the baby undergoing this Carpedium method of CRRT was 2.5 kgs. And it can be started from babies with a weight as low as 1.4 kgs birth weight. So first, let's discuss about the procedure for the PD. Here we are not showing the video. I'll briefly show a diagram and explain the PD method. So before attempting the PD for any baby, we should keep all the things ready that are necessary for doing the peritoneal dialysis. And we should catheterize the bladder and keep the bladder empty. And we should create a sterile field. The person who is doing the peritoneal dialysis along with one assistant nurse is needed. And they should wear the sterile gowns after a proper hand hygiene and hand washing. Sterile gowns and gloves should be worn, and all the things needed for the PD should be kept ready. And initially, first the area around below the umbilicus should be cleaned. Cleaned with the, I'll just show the picture here. So this part just below the umbilicus, at the junction of the upper 1/3 to the lower 2/3, just below the umbilicus, this whole area should be cleaned and draped properly. So after draping the baby, so a small cannula is inserted just in the subumbilical plane, and a fluid reservoir is created by giving around 20 to 30 ml per kg, depending upon the ascites as well as the abdominal distension. So a fluid reservoir in the abdomen is created, then that cannula is removed, and after giving the local anesthesia, the PD catheter can be inserted just below the umbilicus or in the right or left quadrant based upon the size of the baby. All the portholes of the PD catheter should pass inside the abdomen. So you can go through either the same below umbilicus route or right or left quadrant after giving a small nick and providing the local anesthesia to take care of the analgesic part. So after inserting the PD catheter, it is connected to a pediatric burette set, and the dialysis fluid is connected to it, and the outflow is connected to the sterile IV set, which can be placed down. And the PD cycles are initiated. So volume for the PD is around 20 to 30 ml per kg of the dialysate fluid. Initially, the rapid cycles can be done, which helps in the clearance of the fluid and the urea and the creatinine. Later on, the proper cycles can be charted, with in time being 5 to 10 minutes and dwell time around 30 minutes and 30 to 45 minutes, and out time again 10 minutes. So total 1 hour cycles can be done, and these should be strictly monitored on a PD chart along with the vitals of the baby, and strict intake output over the 24 hours PD in and PD out should be monitored. So smaller rapid cycles helps in the rapid clearance of urea, fluid as well as potassium, and higher fill volume leads to greater ultrafiltration and the clearance. So the length and duration. So the success of the PD depends upon the volume which is infused, the osmolarity of the fluid, as well as the dwell time and also the drain time. So it can be adjusted based upon the requirement. So the peritoneal dialysis fluid is a anhydrous dextrose containing solution, which also contains the sodium chloride, acetate, metabisulfate, and calcium chloride as well as magnesium chloride. So the osmolarity of the fluid can be increased by using the 3% fluid in the case of fluid overload, and bicarbonate PD fluid can be used because the lactate PD metabolism will be difficult in case of asphyxia and liver failure. And we will be subsequently monitoring the blood gas, random blood sugar, as well as creatinine and electrolytes. Creatinine can be monitored once every 48 hourly. The other parameters are monitored twice daily. If we note any hypokalemia, then 3 to 4 milliequivalents of the potassium is added to 1 liter of the PD fluid. If there is any hemorrhagic effusion which is coming out from the PD catheter, then heparin 250 to 1000 units per liter can be added to avoid the catheter block. So what are the complications of peritoneal dialysis? Electrolyte abnormalities, hypokalemia, hyperglycemia, hypoglycemia, as well as peritonitis. Peritonitis is defined as more than 100 cells per mmQ or more than 50% of the neutrophils. It is any organism is grown is sufficiently treated with antibiotics for sufficient duration. And the other complications being adhesion to omentum, bleeding, or perforation of the viscera. So that's why whenever we are actually inserting the PD catheter, the tip should be held at like a pen, and it should be stopped whenever you get the giveaway feeling upon entering the abdomen. We should remove the trocar. So the bicarbonate PD is prepared by the following method. 440 ml of 5% dextrose is mixed with along with 60 ml of sodium bicarbonate. This is the solution A, and the solution B is 500 ml of NS. 1/3 of the solution A and 2/3 of the solution B is mixed to make the bicarbonate PD. So this is the stiff peritoneal dialysis catheter which we are generally using. Here there will be holes till this point. So until this point it should be within the baby's peritoneal cavity, and then after inserting this, this is connected to this tubing, and subsequently connected to a 3-way, and the 3-way is connected to a burette set and dialysis fluid from the top, and down it is connected to a sterile IV set for drainage. So this is the PD monitoring chart, which should be given to the nurses whenever they are doing a PD cycle. The time of initiation of the dwell time and out time should be clearly monitored, and the in volume, drain volume and balance, and cumulative input output balance along with urine output should be monitored for every 24 hours. So now let us see the CRRT that is done with the machine. This is the CARPEDIUM machine. I have drawn a small diagram over here. So if you consider this as a baby, I will try to explain the circuit briefly before we go on to the next slide. So here it is like the blood output from the baby is marked in a red line, which comes out through any large vein, and it goes into the blood pump. Here there will be a blood pump which pumps the blood at a rate of 150 to 300 ml per minute. The blood which is coming out from the baby goes into the filter. This is the filter. So in the filter, all the solutes like the potassium, sodium, all these things, and creatinine, excess fluid will get filtered in this filter, and from the filter, the effluent comes out through the effluent pump and goes into the effluent chamber over here. So the cleared blood which is coming out of the filter goes through a deaeration chamber. This is a deaeration chamber over here, and then after this valve, any air bubbles can be removed in this deaeration chamber, and after the crossing the safety valve, the clear blood is infused again to the baby. So these color markings are not to mention about the oxygenated, deoxygenated blood, but the blood having the high urea, creatinine, and solute levels, and the blood which is cleared of them. So there are also 3 pumps here to like pre-replacement pump. This is the pre-blood pump which gets connected to the blood which is coming out from the baby, and this is the dialysate which gets mixed with the filter over here, and this is the post filter replacement fluid which can be mixed over here whenever it is needed, and this temperature should be closely monitored for the baby. We should avoid hypothermia and large volume shifts, and systemic anticoagulation should be maintained by adding the heparin to these solutions, and so whenever the blood is coming out, there will be a negative pressure over here so that the negative suction can happen, whereas in all the other areas, there will be a positive pressure. This is briefly the CRRT machine working. So if you are using that in your setup, it will be useful to go through further videos and articles about the same before using that for the baby. So there was one nice article here about the use of carpe diem machine in neonates and small infants, which is published in Lancet 2014. You all can go through it whenever you are having free time. So coming to the impact of AKI on other organs, acute kidney injury leads to prolonged duration of respiratory support and mechanical ventilation, and higher rates of BPD among preterm babies. This is due to inflammatory cytokines which lead to worse lung outcomes, as well as some neurological conditions like intraventricular hemorrhage and poor neurocognitive outcomes, and also the incidence of hypertension needing medication. The incidence of chronic kidney disease development among babies with AKI is around 6.3%, but it needs further studies to know about the exact incidence. So the mechanism for development of CKD is ongoing inflammation, maladaptive repair and regeneration, and glomerulosclerosis that leads to decreased nephron number. So among the prognostic factors, non-oliguric AKI has a better prognosis. Oligoanuric AKI has higher rates of mortality, 25 to 78%. And these babies after discharge also, they should be monitored for growth, nutrition, blood pressure, as well as renal functions every 3 monthly. So what are the take-home messages from this talk? So we should always closely monitor any baby who is having the prenatal risk factors as well as the high risk neonates like prematurity, sepsis, asphyxia, cardiac surgery, use of nephrotoxic medications. These babies should be closely monitored. In non-oliguric AKI, monitoring the serum creatinine is very important. Always use the modified KDIGO criteria to stage the AKI. So either of those parameters, either a rise in creatinine or a fall in urine output, is an indication to start treatment for the AKI. Avoid the nephrotoxic drugs, and differentiate the AKI into pre-renal, renal, and post-renal. Identify all the causes and treat appropriately. And when the AKI is not amenable to medical management, initiate the renal replacement therapy. The method depends upon the your setup. So any one of the above mentioned methods can be used. So early identification and treatment of these babies improves their survival, and monitoring is very important because the intake output balance as well as the fluid balance is very important for these babies. So these are some of the references which I have used in making this PPT. You can all go through them and have a read. And if you have any doubts, you can either mail me or type them in the chat box. Thank you.